Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, we're discussing social prescribing. I'm speaking to Charlotte Osborn Forde, who's the Chief Executive of the National Academy for Social Prescribing, and Dr. Radha Modgil, who's a GP and TV and radio broadcaster and an ambassador for the National Academy for Social Prescribing. Coming up in this conversation, Charlotte and Radha explain some of the evidence to support the use of social prescribing, what works in projects on the ground, and the important role GPs have to play within social prescribing. They also discuss some of the challenges facing social prescribing, what practices and PCNs can do to ensure their initiatives are a success, and how they would like to see social prescribing develop in the coming years as part of the government's 10-year plan for the NHS. I'm delighted to be joined on the podcast now by Charlotte Osborn Forde, who's the Chief Executive of the National Academy for Social Prescribing, and Dr. Radha Modgil, who is a GP and TV and radio broadcaster and an ambassador for the National Academy for Social Prescribing. Charlotte and Radha are here to talk about the evidence to support the use of social prescribing and what needs to happen at both a local and national level to ensure social prescribing is able to have the biggest impact it can. Thank you both for coming on the podcast.
Thank you so much for having us.
Thank you, Emma.
Charlotte, maybe let's start with you. Can you explain a bit about what the National Academy for Social Prescribing is and what it is you do as an organisation?
Yes, of course. So when social prescribing became part of NHS policy back in 2019 and GP practices were able to draw down funding for social prescribing, the Department of Health set up the National Academy to support with social prescribing evidence, best practice, knowledge and information. So we were set up by government, but we are an independent charity and we work across all sectors. So we do support the NHS with evidence and best practice, but we also work with lots of other charities and national organisations. And we also work internationally to champion social prescribing as it grows across the world.
And Radha, you're a GP and you're an ambassador for the National Academy for Social Prescribing. What does that role involve?
So that really means just championing the messages of what social prescribing is, how it can support people with their health and well-being, and to kind of get the message out there really about what people can do and how they can get involved. It's also to translate the sort of the science and the evidence as well into language that people can hear and understand, and also to engage clinicians, because we need clinicians and other healthcare professionals to obviously get on board with social prescribing and what it is. But really, it's just to sort of champion that. And so I think also sometimes when we're talking about health and well-being, that can be sometimes quite dry in terms of communication. So it's also to try and inject a little bit of energy and life and enthusiasm into it and actually kind of just broaden people's perspectives on what actually being well actually means.
And why was it you wanted to get involved with the National Academy? Why do you think social prescribing is a good thing?
So I've been a doctor now for over 20 years, which is quite scary, but it's a truth. And over that time, obviously, I've done many different specialities. I've worked in many different hospitals and trusts and different organisations. I think for me, one of the key things is really seeing patients and seeing what actually is impacting them. For many years, I just felt that there was a bigger picture than kind of the medical approach to health. That is life events, bereavement, divorce, separation, financial problems, loneliness, all kinds of things that people were telling me. And so for me, social prescribing really is about tackling those sources, those kind of the source of the problem at its root, but also not just the individual improving their lives and connecting them with activities, but it's also actually about bringing communities together. The world we live in, it feels sometimes a bit divisive, a bit tricky, a bit challenging. And I think social prescribing also has a remit in there that actually it's not just the individual that benefits, but it's also the local community which benefits as well. So sometimes social prescribing, I think, represents what we knew when we were little. You know, nature's good for us. Seeing our friends and other people are good for us. Music and arts are good for us. Having information to know what to do is good for us. And yet we seem to have lost that along the sort of the path of health and well-being. So it was really about getting back to those basics and reinvigorating that, I think, as well.
So part of the reason we're talking today is because the NASP recently published a report setting out some of the evidence that backs the use of social prescribing. Charlotte, can you explain what's in that report and what that research found?
Yes, for us, this is a really important report. So the first thing to say is it's not academic research, and typically our reports at the Academy are about academic research. But what we found was that there is a lot of data and reports within health systems. So within primary care networks, within integrated care boards, that were showing some really powerful impacts of social prescribing on NHS demand. So we went out to all of those NHS organisations and to our contacts there, and we simply asked them, what data are you collecting and what reports do you have that you would share with us and that we could use to highlight that social prescribing is making a difference on NHS demand? And there was a lot that came back. So we spent about 6 months really looking at that internal research, data and reports, and collating it, comparing it, and publishing a summary. And that's the report that we published last month. It looks in detail at 9 particular examples. Many of them have matched controls, and what it shows on balance across the board is that social prescribing is substantially reducing demand on NHS, particularly looking at unplanned admissions to hospital, A&E attendances and GP appointments. And even in those different contexts and fairly different social prescribing schemes, we see this theme running throughout the programmes. So that's really helpful to us because we know that there is lots of academic research and lots of evidence about the impact on patients, but this is the first time that we've got a really good sense that it's actually making a difference. Now it has been deployed throughout the NHS.
You also published a rapid review last year that set out the economic case for social prescribing. What did that find?
That found very similar trends. So that was a piece of academic research, and it looked at very robust peer-reviewed research that's been published. And that showed, again, it looked at around 19 different studies, and it showed that there were about 5 different methodologies used by researchers to understand what the impact is on economic benefits. And it found that, again, across those 5 different approaches, there were strong economic impacts and strong benefits. And typically those included things like understanding the social return on investment. In many cases, similar figures were emerging from those reports. So very often between £2 and £4 social return for every £1 invested. And we also looked in that report at economic research on GP appointments and A&E attendances. That data is quite hard to come by because actually research tends to take about 3 years between when it's first envisaged and when it's published. And as I said, social prescribing is really only being deployed over the last 5 years. So we're still waiting for much of this research to be published. But what we do have in those early findings is really encouraging.
And Radha, we're talking about the findings from research that's been going on. Do you see these benefits in your day-to-day work? Do the findings of this research back up how it's actually working on the ground?
Yeah, so over the last few years, I've been working in the National Academy and visiting lots of different projects around the country, lots of different programmes where people are actually in action doing the social prescribing. I've done lots of short films and clips, spoken to not just people who work in those projects, but also the people who've benefited from those and the participants within those projects. So we've covered libraries in Brighton. We've gone to Bart's Health, where they're actually using social prescribing in secondary care for people who have had heart attacks, which is, again, really interesting that that's coming into secondary care as well. Gone all the way up north to talk to a project that's doing things around financial well-being. I think through all of those different films and different projects, there are some common themes really that come out. Mostly that people feel better when they're connected to people and to places. They feel a sense of purpose and belonging, but also the other benefits. So, for example, for the financial well-being service, that was with the Citizens Advice Bureau, the fact that sort of knowledge and skills and information are there and sort of people who have those skills and who can impart that knowledge to that person can really impact someone's well-being and how they're feeling about their finances and the stress they're under and the impact on their mental health. But also projects, for example, I went to see a dementia choir who was singing using music, and the carers and individuals who were part of that project spoke to me really passionately about the changes they'd seen in that person, their memory, their levels of agitation had reduced, for example, but also the support for the carers themselves who'd been very isolated and very stressed, had been able to talk to other carers and had an opportunity to bond with the person they love in that choir and do something they used to enjoy together. So I think connection, reduction in loneliness, of purpose and someone caring about them and being part of something and having a bit of routine, but also the science of things like music, how that impacts our brains when it comes to conditions like dementia, for example, and actually how that can reduce the need for medication and reduce agitation. So lots of different aspects. But it's really interesting how, like I said before, it's not just the individual who's benefited, it's carers, it's the local community, it's people working in that project in terms of satisfaction and the satisfaction they get from their jobs. Really inspiring, I think, and uplifting at a time when sometimes the conversation around health and wellbeing and what's happening in the world can be a little bit depressing.
There was some other evidence that was published recently I just wanted to ask you about as well, Charlotte. That was kind of separate from the National Academy of Social Prescribing. That was about the benefits of green prescribing. That was quite a big bit of research for that. But what do we mean by green prescribing, and what did that research find?
So that programme is actually called Tackling and Preventing Mental Ill Health through Green Social Prescribing, which I think sets the scene a little bit better, but we call it Green Social Prescribing for short. What we mean by Green Social Prescribing is where the person is ultimately connected to something that's nature-based. So that could be a walking group, it could be a community allotment, it could be nature conservation. They still go through the social prescribing pathway where they are asked what matters to them and have all of those other holistic needs addressed. But one part of their action plan is around connecting to nature. And this is a really big government programme. The first phase was 5.7 million cross-government funding, and the evaluation that was published is on that first phase. And what it showed is extremely useful. So it really looked at what happens when you invest funding into 7 integrated care systems, and that funding is used to strengthen pathways between primary care and mental health services and the voluntary and community sector. What is the impact on patients, and how does green social prescribing compare to other conventional NHS interventions for mental health? And what it found was, again, hugely positive. It found, for example, that 57% of people that took part were from the most deprived communities. So it's really reaching people that it needs to reach. It found significant improvements in well-being. It found reductions in anxiety. They also compared green social prescribing to those other interventions and found they were cost-effective and just as impactful as interventions such as CBT and other things currently available. The programme was so effective that Treasury have funded a second phase and committed a further £2.3 million to further look at the detailed data and evidence for potential wider rollout. So it's a really transformative programme. The report has been published by government on the DEFRA website, and we really hope it will lead to much greater strategic attention and investment in social prescribing.
It's a really positive story, that, isn't it? One thing I think is quite important to mention here is, Charlotte, you wrote a piece for GP Online recently. You pointed out that the ultimate aim of social prescribing is not really about relieving pressure on the NHS. It's about helping people to stay healthier for longer. And that's then what ultimately benefits the NHS. I mean, how can we ensure that patients always stay at the heart of local approaches to rolling out social prescribing?
I think that's a particularly pertinent challenge at the moment, because we all know that funding is incredibly tight for services across the board and that the NHS is under intense pressure. And what we have seen is that social prescribing, like any other part of the NHS, can be under pressure. And that might mean that link workers have less time to spend with patients. They are less able to have the capacity to go into communities and form those relationships with community groups. They might be less able to have the time to do the home visits, which for the most vulnerable are really important. So I think the first thing to say is, for social prescribing's impact to be effective and for it to have this impact on reducing demand, we have to make sure that it is high quality and that it is delivered according to what is NHS guidance in terms of link workers literally having the time to form those relationships and trust with people. I think the NHS guidance for social prescribing that was published when social prescribing became part of the GP contract is really key, because it sets out very clearly the mechanisms, the approach, the workforce, the skills and competencies, and the support and supervision needed that will ensure that it is focused on the individual needs of patients and it doesn't become a purely mechanistic approach to support GPs with access and demand reduction. So the NHS guidance is one thing, but also, of course, lots of opportunities around genuinely embedding voluntary, community, neighbourhood and faith organisations into primary care, and link workers really should be empowered to be that link and to continue to build those relationships. And that, again, will help us ensure that it's the holistic approach which link workers are building on.
Radha, perhaps worth bringing you in here. Charlotte's touched on that a bit, but what ingredients are needed to be in place to make social prescribing initiatives a success? You said that you've been around the country and seen lots of things going on. Where they're working well, why is it that those schemes are working well?
A couple of factors. I think the main one is sort of innovation and enthusiasm. I've seen some really passionate people who have seen a problem, who've wanted to change something for patients and to provide something, and they've gone up and started it, and they've kind of got on with it. So I think that enthusiasm and that passion, I think, is really important. And innovation. We've seen lots of different projects coming together in different ways for different demographics and different groups of the population which aren't served particularly well. I think also it's really important for healthcare professionals and people who are referring on to link workers, clinicians, to really understand what social prescribing is, and to look at the evidence, to look at the science, to ask questions, because obviously when something is new and different, it's important that, you know, we can give them confidence in what it is and actually the fact that it works. And then I think it's about working together. It's about collaboration and teamwork. So it's about, you know, clinicians and the healthcare professionals seeing link workers as part of the solution and part of that answer together and working as a team. We all know if we work in the NHS or any organisation that, you know, without teamwork, we can't really do anything. I think it's also about trying to communicate with individuals and patients to allow them to understand what social prescribing is, about how it can potentially benefit them, and also to, I think importantly, answer any questions or concerns people have about it. Sometimes we focus very much on the benefits and what we think people will take from that messaging. We need to understand what the obstacles are for people actually accessing it. Is it transport to that project? Is it that they can't get anyone to, you know, look after their dog on a Thursday? What are these things? And that's part of a few things that link workers can actually look at and address. So it's about looking at the obstacles, the fears, the worries about that. Remember, for patients who have been isolated or who have, you know, long-term health conditions, it can be very scary and frightening for someone to suggest to go to something new, to a new place with different people. So it's about trying to understand that and ask the questions that will help them feel that they can be confident enough to try it out. Ultimately, as well, I think it's also about making sure that healthcare professionals and clinicians are referring the appropriate people. Sometimes link workers have referrals and that person may not be suitable for that particular project. So it's about understanding who's appropriate, who's not, asking the question, but also recognising that the medical approach is not being thrown out the window here. It's about working in parallel and all of these things working together appropriately to benefit that individual.
Yeah, I was just wondering, obviously Charlotte said earlier that it's not been around for ages. The social prescribing is something, but the way it works now, it's only really been since 2019. There's been a real push on making. Do you think that, from your experience, that it's starting to be seen as a real normal part of primary care and general practice now?
Yeah, I think, like you said, social prescribing is not a new thing. It's been going on for decades, but in a less formalised way, without a label or a name to it, run by people who've been very, very enthusiastic and innovative previous to this. But I think now it has been formalised. It's been given a name and a structure. I think it is becoming much more, you know, part of that kind of mainstream conversation. Lots of colleagues and GPs that I know talk about it in that fashion, in that manner. But I think we still have to be very aware that for some clinicians, healthcare professionals in some areas, it's not necessarily at that level, and we need to try and make that equitable across the whole country and across all areas as well.
All of this, obviously, we've been talking about, really highlights that social prescribing can make a really big difference to patients, but there's still a lot of challenges, which you've sort of touched on a bit already. But Charlotte, what are some of the real problems and issues social prescribing link workers are kind of facing on the ground?
I think these sorts of issues and challenges they're facing will be mirrored by most other NHS staff. It is incredible demand for what they do and how they can manage that. And I think increasingly the patients that they're working with have very complex needs. So when social prescribing was rolled out, it was really envisaged as a very preventative service. So thinking about keeping people well. But actually, since the cost of living crisis, increased NHS waiting lists and people living with multiple long-term conditions, not necessarily able to access the treatment that they need when they need it, link workers are filling a really important role to try to keep people as well as they can, but also dealing with problems around housing, around finances, around debt. So the complexity of people they're working with can be very intense. That's one issue. The other issue is the wider systemic issue within the NHS, meaning that the link workers, there are not as many as there could be in the system. GP practices and primary care networks have discretion really around how many link workers they have and how many patients are referred. And when they have so many other clinical pressures, it can be hard to really find the time to focus on building up a strong social prescribing service and making sure that it's available. So we're very clear that link workers really do need very thorough clinical and management supervision. They need opportunities to come together with their peers. They need the time to engage with community groups, and they do need the time to properly engage and have the time to work with patients. And of course, we hope that through the opportunities in the next year with the 10-year plan, that there will be structural commitments around ensuring that primary care networks can have the funding and the time and the structures to enable them to allow social prescribing to fulfill its potential.
The government's talked a lot about this. There's three things, aren't there? But one of the big ones is moving out from hospital to community, from sickness to prevention. Do you see social prescribing having a really important role in both of those things?
Absolutely. And I think that's both the opportunity and the challenge. It certainly has a role in those elements. And just to go back to the report that we published looking at the impact on the NHS, what we found is where primary care networks and hospital trusts had the opportunity to step back a little bit and be more strategic about social prescribing and think about how it was helping them to achieve those aims, which again are not new. I mean, we've been talking about prevention for a long time. That's where it was most effective. Examples, Calderdale, where they have an ageing population and need to address frailty, that social prescribing was really integrated into their approach to frailty and really proactive. And link workers were going to do those home visits, but really thinking holistically about the older person's needs and making sure they were navigating the more clinical services that the older person could benefit from. In Peterborough, we have examples of where social prescribing's been really well integrated with the mental health practitioner roles and secondary mental health care. It's those sorts of examples where a more strategic approach and recognising that it can achieve those shifts was where we saw the biggest impact overall. And I think the danger is if there is a perception that if you just employ a link worker and off they go, that's going to be the solution. It isn't necessarily going to have the impact we need without it being integrated in those bigger shifts.
Radha, how involved do GPs need to be in social prescribing locally? What role should they have within all of this?
Well, GPs are absolutely integral to the success of social prescribing, as are other healthcare professionals, because without them, we can't identify the people who actually need the support and get into the whole system of social prescribing. So this time, general practice is under huge pressure. GPs really are struggling with workload, demand, and all kinds of other things. But I think it's about making it as easy as possible for them to get involved with that. They haven't got a lot of time, they haven't got a lot of energy to put into another thing. So it's about trying to make it as easy as possible for them. But also they are not just the people who are doing the referring, but they're also the people who are championing that to their patients and talking about it and discussing it. People have confidence in their doctors generally, and they trust their doctors. Still also one of the top professions and roles that people have trust and confidence in. So it's really important that GPs are part of that conversation, but also for them in terms of, hopefully helping reduce their workload and supporting them with who needs what. This is not just as I said before, it's not just the individual who benefits. It's actually looking at the whole system, the GPs, the GP practices, other services, but also all of those incredible organisations that actually provide these brilliant activities, about sort of supporting them and recognising their work as well. It's about trying to not look at an individual's health and wellbeing in isolation, but really trying to look at the whole community and say, actually, how can this all work together? So GPs are absolutely vital, but I think at a time when GPs are feeling a lot of pressure and stress, we need to be doing everything we can to make it as easy as possible, to give them the right information and the information that's succinct, and also the evidence to back that up so they can actually make the decision for themselves in an easier way.
And what advice would you give to GP practices, primary care networks, on how they can make the most of social prescribing and how they can get the best from it in their practice and for their patients?
I think the report that we recently published really showed some innovators there, and there is some amazing work going on that we hope to highlight and further scale. I mentioned Calderdale and Peterborough, but also in Kent, where there are primary care networks who've really tailored specific roles to their population needs. And one of those is around children and young people, mental health and neurodevelopmental disorders, recognising very significant waiting times for clinical services, recognising the hugely fractured and difficult to navigate range of organisations that can support through those sorts of issues. And they've recruited dedicated navigators that really play a role that not only is about social prescribing, but it's about being the one person for the family that navigates the system and supports the GPs with some of the less clinical work that they were asked to do around, say, chasing referrals and those sorts of things. And that's been hugely impactful. Where it's tending to work very well is genuine collaboration with the voluntary sector. So that example in Kent, they don't employ those navigators directly, although they're based in the GP practices. They commission a local voluntary organisation with expertise in that area and with links to local authorities, schools, etc., who employ the link workers based within those primary care networks. And they're showing some absolutely amazing results, not just with children and young people, but also with adults, and have shown data around 20% reductions in A&E attendances and GP appointments. There are lots of opportunities. The other key area is around what the NHS call targeted proactive social prescribing, but we prefer the term data-driven. And what this means is using your medical record system and using the coding on that system to identify cohorts of patients who could benefit from being offered social prescribing and encouraged to access the service. And they've done this in a very interesting way in some Sussex PCNs, and that's showing really positive results, not just in terms of engaging people that might not otherwise engage, but also in terms of effectiveness. And we're finding out more and more from some of the data we have who are the most potentially impactful cohorts of patients. For example, actually, they tend to be of working age. Potentially, they've had a number of Med3, so sort of fit notes. They've got multiple long-term conditions, but not complex. And they're the patient cohorts that can benefit in terms of reduced demand on GP systems. So I think there's some really exciting work coming out, which we hope to share over the next year to give other primary care networks some really good examples of things they can implement quite quickly that will make a really big difference.
As a GP, as a doctor, you want to see your patients getting better. And it's really important, I think, at this time when the GP workforce is under such pressure in terms of retention and how they're feeling about their work, that actually it's important to recognise what can sort of GPs get out of it or how can they get engaged with it. It's about seeing that change in their patients, because job satisfaction is everything. And actually that also then improves the GP, their well-being, how they feel about their job and their role, gives them the motivation to continue and to do the best job they can. So I think actually for GPs as well, if they can go and actually sort of see the results, they can see the impacts, they can talk to patients, but also if they have time, and I know that's a very difficult resource at the moment for GPs, but if they have the time to go out and visit projects and to talk to link workers and have that back and forwards, if they can see an improvement in their patient and how they're feeling, I think that is something you can't really quantify in terms of benefit. And a lot of clinicians are feeling quite low about their role and their job and under pressure. And we all know that when someone can see a difference they're making and they know that that actually is supporting somebody, that their job matters and they're able to do that, then I think it really does help with all of those different factors as well.
Yeah, that's such a good point to make there, Radha. Charlotte, you've just published a report for a National Social Prescribing Fund. Why have you done that and what do you want that fund for?
Yes, so just yesterday we launched the fund, and this is a piece of work that's taken us a good couple of years to do, working with the National Lottery. So we know now that there are link workers within primary care and they are doing an amazing job supporting patients. But ultimately, the outcome of that work is to connect people with community activities, so groups and services in the community to help people stay well in the long term. But what we also know is that those groups and charities are under incredible pressure Link workers tell us it's very difficult to always be able to find what people really need in the community because of the pressures on those community groups. The National Council for Voluntary Organisations published a report, their almanac, which showed that funding for smaller charities has dropped by 25% in 1 year. So on one hand, we have incredible demand for social prescribing and for those community activities, but a rapidly reducing supply of activities and groups and services. So we are calling for a strategic approach to investing into community groups. And what that would look like is making the most of existing systems and architecture in healthcare. So we know we have integrated care boards and integrated care partnerships. And we are calling for an approach that would match national funding with funding at that integrated care partnership level, channeled into the smallest community and neighbourhood groups for health and well-being, which would be very much determined locally, but focused on inclusion, health and well-being, and better mental health. So the next step for us with this report is really to advocate for national funders, whether that is one of the lotteries, whether it is Treasury or government departments, to commit to some level of investment into those integrated care partnerships, which we know the integrated care partnerships will be able to match with local investment from philanthropic sources, private sector, employers, local authorities and others, and together collaborate and channel that funding down into the community groups who most need it.
Is it just about more money from the centre or from government, do you think, or is there anything else that could be done at a national level to help boost social prescribing?
Well, we've been thinking about that a lot because we have submitted our response to the 10-year plan consultation, and absolutely funding and investment is one thing. But there's also, as Radha's pointed out, a real need around training and information sharing. So social prescribing is still highly innovative. People don't necessarily understand how it works and aren't making the most of it. So one thing we're suggesting is a much greater approach to raising awareness, to education, to training across the NHS, and more strategic training for link workers themselves. So we know that many primary care networks will employ link workers, and they may come with a background and knowledge that can help them deliver the role, but actually not always do they have that, and there's not always a good understanding of the skills and competencies required. So much better easy access for training for link workers that PCNs can tap into, and for a much stronger approach to neighbourhood health. So it's something that's coming up again and again, but actually the government and others can play a really important leadership role in saying that neighbourhood health, this is what it means, this is how we achieve it, and it's really important. So beyond funding, it is about those visible commitments, statements, enshrining in policy so that local commissioners and local decision makers can be confident that social prescribing is an evidence-based mechanism to help those achieve those shifts.
This is obviously why you're so focused on getting together this evidence to support its use, because that's what will make the argument for people investing in this at a local and a national level, isn't it?
Yeah, that's absolutely right. And it's a challenge that has come to us over the last 5 years from all different sectors, whether that's from government ministers, clinical directors, GPs, is that when resources are so tight, and if you had, 40,000 to spend on a nurse or a link worker, and you've got incredible demand on clinical time, it's only ethically right that we are able to demonstrate that the impact will be equivalent or greater. It might look different. It might be a longer term impact. It might be on a broader range of people. But that evidence is really key. And we know in exactly the way that Radha's talked about, it's instinctively common sense, the right approach. We see it in our friends, our families, our patients. But without that really clear, robust evidence of clinical benefit and of cost savings, we won't be able to make that shift to investment in the actual roles and organisations that we need. But we've made incredible progress there, and we're really confident that with the standard of data and evidence, both in terms of cost savings and in terms of clinical impact and clinical outcomes, really social prescribing will be a core plank of future NHS policy.
How would you like to see things going forward for social prescribing? What do you want to see in the 10-year plan, and how do you want social prescribing to develop as we move into the next 5 years or so?
There's obviously incredible pressure in terms of A&E, hospital, all kinds of things. It's such a difficult environment. In all my 20 years of working in the NHS, I haven't seen such a difficult environment. We need to balance that alongside prevention and looking at actually kind of what is going to lead people down the path of ill health. So for me, I think I would like those two things to be in parallel, that emphasis on prevention and also on community health, being alongside the crisis type of management and the intense pressure that we have. We can't sort of ignore one or the other. I think we have to do both in parallel, which is a difficult job. It's challenging, it's tough, it's not easy. But I think unless we do that, we're not going to be able to sort out the crisis end of it. So I think for me, it'll be about recognising that and to be able to kind of put those two together and work with those together. I mean, I mentioned the project in Bart's Health before about people who have already had heart attacks, and this is about secondary prevention of that and the social prescribing activities that were related to that. And one of the things they really mentioned in that project was the impact of having a heart attack on patients' mental health, and particularly male mental health, and also the financial implications of that in terms of jobs and fitness to work and everything else, and financial difficulties. So that's just one example of how actually secondary care, primary care can work together. That more kind of crisis management and acute treatment can actually work together with social prescribing and prevention.
Yeah, and Charlotte, what would you like to see happen over the next few years?
We believe that the evidence is now robust enough to advocate that social prescribing should be rolled out across the NHS. So we have seen huge success within primary care and huge favourability now with GPs. About 97% of GPs are now favourable, according to Department of Health survey. But that's still not the whole wider NHS. So we're calling very strongly for social prescribing to be rolled out in secondary care, specialist care. The example that Radha's talked about in St Bart's is a brilliant example of that. Essentially, every patient should be offered the opportunity to say what matters to them and to be connected to something in their community that keeps them physically active, creative, socially connected, and addresses their concerns. That should be a basic entitlement. The detail of how it's delivered, whether it's within primary care, whether it's within link workers, within dedicated programs, is less important. But what's important is recognising the social determinants of people's health and giving patients the opportunity to reflect on how they can help themselves to stay well. The 10-year plan is an opportunity for us to embed that structurally, and that's what we'll be calling for.
That was brilliant. Thank you both for coming on the podcast. Thank you.
Thank you so much.
Thank you, Emma.
Well, that's it for this week. Thanks so much to Charlotte and Radha for taking the time to talk with me, and thank you for listening. This is our last episode of 2024, and I'd just like to say a big thank you to all of you for listening to the podcast throughout this year, and to all of the guests who've taken part. I'd also like to wish you all a very Merry Christmas and a Happy New Year. Don't forget, you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.